Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith Rogers. On Friday, January 31st, a number of important data sets and pages on the website of the U.S. Centers for Disease Control and Prevention went down. Researchers, public health workers, and citizens could no longer find information related to infectious disease, environmental health, and adolescent health. In today's episode, a conversation with Dr. Nirav Shah, a member of the advisory committee to the director of the CDC and co-chair of the advisory committee's data and surveillance workgroup. He speaks to me about the critical work of the CDC, the value of those agency data sets, and the questions being asked about what's going on. Just a note that Dr. Josh Sharfstein, producer and regular podcast host, is also a member of this advisory committee and a co-signer of the letter mentioned in this episode. As always, these podcasts are a conversation between the participants and do not represent the position of Johns Hopkins University. Let's listen. Dr. Shah, thank you so much for joining us on Public Health on Call. How are you doing?
I'm doing well. Thank you. So nice to meet you, Lindsay.
Nice to meet you too. So tell us a little bit about your background and what you're doing now.
I'm a general internist by training with some public health experience as well. I've served as the health commissioner of New York State. I've been the chief operating officer for Kaiser Permanente in Southern Cal. And most recently, for the last few years, I've been on the faculty at Stanford University at the Clinical Excellence Research Center.
And today we're going to talk about the CDC. So can you tell us a little bit about your work there?
For the last few years, I've been an advisor to the director of the CDC, part of this advisory committee that's formally written into law and enabled by Congress, where we are to provide advice on the strategic plan and how the CDC might be functioning in many different areas.
Tell us, what is the CDC? What is its essential function?
The CDC is unlike any other federal agency, and frankly, there is no agency like the CDC anywhere else in the world. It operates under the Department of Health and Human Services, or HHS as we call it, in the federal government, and is headquartered in Atlanta, Georgia. The CDC plays a crucial role in protecting public health and ensuring the well-being of people across the U.S. and, in many cases, worldwide. The mission of the CDC is to prevent and control disease, injuries, and other health threats through research, education, and health initiatives. Under that broad umbrella, it does thousands and thousands of things, and we've become reliant on it in ways that we don't even understand as a public.
Tell us a little about the day-to-day work of the CDC.
The day-to-day work touches all of us in so many ways we don't even know. I'll give you an example. When you go to a restaurant and eat a meal, you expect not to get sick from that meal. Well, how does that happen? That happens in part because the CDC has, with others, created rules around safe food handling, around how do we make sure that our food supply is safe that's getting to the restaurants. And anytime, anywhere, that system breaks down, it's the CDC who's at the front lines of figuring out what happened, why it happened, how can we correct it before people die. So you may occasionally hear of a listeria outbreak or something like that. The reason that's happening very rarely is because of all the work that the CDC, along with state, local, and other partners have done to ensure the adequacy and safety of our entire food supply.
So you mentioned that the CDC is under the umbrella of the federal government, headquartered in Atlanta, but then here you say they're working with local partners. Tell us a little bit about how it's structured. How does it get its day-to-day work done?
The vast majority of what the CDC does is actually through its local partners. So 50 states and multiple local public health counties have direct partnerships with the CDC where Congress appropriates money on a given topic, let's say HIV and AIDS. The data that the CDC collects on those topics come from local partners, whether it's states or local jurisdictions, and that data back and forth aligns around what are the policy priorities. What should we be doing to help people who are suffering from a given condition? How do we identify the hot spots? Where do we start to put money to have the most effective impact on improving health and outcomes and wellness for Americans? So it may be data from rural Arkansas that comes in from a local partner to a local health department up to the CDC. And what the CDC can do then with that data relative to all of the data across the 50 states is to help identify opportunities, help identify where we should target resources and the kinds of programs that should be used to target those opportunities, whether it's opioid addiction, fentanyl, infectious diseases, you name it, across the board for anything related to health and wellness.
So the CDC might see trends, they might see emerging concerns, things like that, before maybe other agencies?
Better than anyone else, the CDC has the data collected to do that. And then with partners, many people can look at those trends. So it's not relying just that the CDC may house the data, but then that data being available on the website allows everyone to use that data for their own purposes. So let's say you're in Boston and you're trying to target which part of the city will best help homeless individuals, unhoused individuals receive food. You can get data on homelessness and housing and all of those data from the CDC. So you can target and build programs to meet the needs of the people where they are.
So the CDC is housing all kinds of data. Can you give us some more examples of what's under its purview?
Anything from clean air to how students are doing in schools. We know that with COVID, students have been under a lot of pressure. When rates of anxiety and depression that are through the roof, with issues around vaping and its increased use of other non-tobacco products, these are opportunities for us to help our children. We don't necessarily, without those data, we can't better target who's most at risk with the resources to help that. Whether it's an anti-vaping program, whether it's other programs to help with anxiety and depression or other mental health challenges. These are opportunities that can be identified based on the data that the CDC collects across the United States.
So from food safety to mental health to clean air to, you mentioned HIV programs, it sounds like the CDC is a really essential data hub for our health system.
There's nothing else like it. And when you talk about a single data set like the Youth Risk Factor Behavioral Surveillance System, that's a mouthful. That's an example of a data set that most people would ignore or not really know about. And yet, because it exists, we're able to help people where they most need it.
So let's talk about what's happening now. The Youth Risk Factor Surveillance System is one of some data sets that recently became inaccessible. Tell us what's going on.
Well, over the last few days, we've seen a lot of back and forth in terms of uncertainty about what needs to be publicly reported, what is allowable. And a few days ago, we noticed that a lot of data sets that many folks across the country have relied upon are no longer available on the CDC website. And as a result, we were not given any advance warning. We didn't know why certain data sets were removed and others weren't. We don't know the schedule of when they might come back up or any other changes that may happen in the interim. And as a result, a number of my colleagues and I on the advisory committee to the director in our personal capacities have come to the CDC director, the interim director, and asked her if we might be able to help inform any issues that have come up. Are there ways that we, given our status, can help identify opportunities to get the data sets up as quickly as possible, understand the reasoning behind why certain were pulled down and others weren't, and what the longer term plan is? Because part of the uncertainty affects thousands and thousands of downstream partners. All our state and local county and other researchers and others who are reliant on the data don't know what's going to happen. Are they going to have to rely on old data that they may have? Are there opportunities to update the data, or will the data be fully restored as it was before? The collaboration that happens with the CDC and all the partners that work with the data has been fundamental to improving the quality of the data, the quality of the signals that allow us to make actionable insights, to make public policy and recommendations that actually improve health and preserve and protect all Americans. Without that data, we're left blind. So the purpose of writing that letter was to understand why this happened and what we could do to help the CDC get them back up as quickly as possible.
Can you tell us a little bit about what you know is no longer there at this time?
I can't tell you by this minute because I understand several of the data sets are coming back. But for example, the Atlas of HIV, hepatitis, TB data, the social determinants of health data, all of these data sets that have helped guide funding and policy decisions, such as directing federal resources to rural U.S. counties where there's high rates of hepatitis C, contributing to efforts to combat the national opioid crisis. All of those data were taken down as of Friday. Another example is the Youth Risk Factor Behavioral Surveillance System. This is a resource that helps identify those emerging issues and plans and evaluates programs to support youth health. It is the best picture of what's going on at the national, state, and local levels, and used by doctors, lawmakers, educators, everyone to inform what those community-based programs are. It's important to understand mental health challenges facing youth. Without this data set, we may not be able to do that.
And so you say that the data sets were taken down. So someone, in one of these local offices may have gone to, a data set that they're using for a project, and suddenly there was just nothing there. I mean, do we know where they went or who took them down?
We don't. It would be speculation. We do know that there are many reasons why those data sets may have been taken down. A series of executive orders from the president and the administration recently have talked about different definitions and changing how we define gender or sex, how we define and what we should do with such data. As a result, those data oftentimes included data on sex and race and gender and other things that may have been affected by the executive order, but it's speculation to say who took which data down for what reason. We just know that when folks have tried to access the data, a 404 not found error occurred. And so that lack of knowing is part of the problem. We are very used to a high level of transparency otherwise.
It sounds like in part what you're asking for is that transparency and learning more about what's going on. Is that fair to say?
I think that's fair to say. I think absolutely we want transparency, not only in the rationale for making the data sets and websites inaccessible, but then also understand what would be the consequences of removing those data sets. There are, as I mentioned, potentially numerous people using each of those data sets. And we have to have a reasoned process in terms of what is the impact downstream. Further, we wanted to ask if there was legal authority to make those changes, or if not, what is being done to safeguard those data sets and other information removed from the websites, along with a timeline of when the data sets and websites would be restored.
Now, is this data still being collected, or is it just, temporarily unavailable? Do you know anything about that?
We're hoping that most of the data sets will be restored very soon. My hope, that certainly is the hope. The reality is no one knows until it happens. The data are collected oftentimes in partnership with local and state and regional governments and other agencies. So it's not just the CDC collecting the data. It's in partnership with 50 states and beyond. And so the data is being collected at some point. A loss of a weekend may not be the end of the world, but we certainly wouldn't want it to extend much more than that. And more importantly, we want to make sure that if such a thing happens in the future, it's explained, there is conversations and understanding of the full implications of when these data are brought down. What does that mean to everyone who's currently benefiting from this? The example I'll give you is if you suddenly started to worry about, is the food safe I'm buying at the grocery store? Is my child safe at home when there's lead in the paint? Are there issues with the clean air if I go outside on an afternoon? All of those are informed based on the data sets collected by the CDC. And so we suddenly miss them. All of those things could potentially break down. We know public health is working when nothing bad happens.
Is there any precedent to this? Has something like this ever happened before?
That's part of the problem here. This is completely unprecedented. Nothing like this has ever happened before. And we're hoping that this is a transitional process until folks sort things out. But we do want to make sure that it doesn't happen again and that we put in the safeguards to ensure that these vital data that are crucial to so many lives across America and the world are available for science and evidence-based policymaking and all the other good things that come as a result of it.
So there's a lot in the news about this, and I think what most people are seeing is something to the extent of like CDC pages go dark. Can you help us understand, why this is such a big moment and help us put this into a little bit of perspective?
The example I'll give you relates to HIV and AIDS. We know that we have limited resources to help combat this scourge, and to the extent that many of these data sets help us identify where and when the problem is happening most. Where is HIV spreading? Who are the populations at highest risk? We can then target resources, whether it's educational resources, prevention resources, PrEP treatment resources, all of these to those who are at highest risk. The same amount of dollars spread across everyone in America would lead to no benefit. But if you're able to target it to the few people who are at highest risk, we can actually combat HIV and AIDS and start to reverse the trend and get toward our goal, which is net zero for HIV and AIDS. This is a very simplistic example, but it's a real example on the data that were not available for agencies to target those resources appropriately.
So it sounds like essentially public health is not able to work without this data. Is that accurate?
That is very accurate. The whole point of public health is to use limited resources in a thoughtful way to optimize of all Americans' health and wellness, whether it's prevention, whether it's targeting treatment, whether it's post-surveillance, all of the above. All of that takes data to help us understand how do we create the right strategies and target the right people with the right messages and the right treatments and the right kind of prevention and other things. Public health cannot fly blind. Without these data, we're flying blind.
So you've submitted this letter to the acting director of the CDC asking for more transparency, just, asking what can we expect? How can we help? Do we know what the scope of this is? What do you expect might happen next?
Well, we're here to help. The whole point of the advisory committee to the director is to help get through complex times and help advance the CDC strategy and work deep in the weeds sometimes to help with some of the data issues, some of the other issues. I co-chair the data and surveillance workgroup for exactly that reason. As we try to rethink what we need in a post-COVID world with data and surveillance, it is a fundamental difference from what we had prior to the pandemic. That is an example where the committee has come up with recommendations that have helped the CDC formally and are being enacted. Same thing with this situation. We don't know what we don't know. We want to be there to help. And our hope is that in writing this letter, the acting director will reach out and schedule a meeting and help us.
Dr. Shah, we really appreciate your perspective and the context on something that's been in the headlines. And, I think to a certain extent, it's kind of helping people understand how public health works. So there's a little bit of an opportunity here, would you say?
More than a little bit. I think we all benefit when public health works. We don't understand its benefits until its absence. And yet all of us in America enjoy some of the best lifestyle, some of the highest levels of health and wellness, healthy longevity. All of those things are a direct result of a well-functioning public health system. When you lose the data, when you lose the foundation of trust that's been built up over generations in public health, the system starts to break down. Today, I believe we can recover, but there's only so many hits that public health can take before it starts to break down, and we start to lose the many gains we've enjoyed as Americans. I'm hopeful that everyone stays vigilant and everyone asks for and wants and sees the benefit of all of these data and asks for their urgent return.
Dr. Shah, thank you so much for joining us on Public Health On Call.
It's my pleasure. Thank you.
Public Health On Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Sasiri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.